Okay, I think we can make a start. Thank you very much for joining us. I'll just start by doing some introductions. We're very much hoping this session's going to be interactive, and we're very grateful to Thrombosis UK for putting it on. So we're here to talk about problems with heavy periods in women who are on anticoagulation blood thinning treatment. We have a panel of some doctors who work in this area, and we will go through some questions and answers and hopefully have some good discussion. So I'm just going to introduce the panel first, but before I do that, just to make everyone aware, you will get a follow-up invitation after today's session, asking you to attend a similar session next week, which is a more focused discussion looking at a potential study in this area. Looking at how we can help women who have heavy bleeding on anticoagulation. So if you're available for that session, we would be very grateful for participation. And your opinions really do have an important part in how these studies are developed. So please look out for that and register for it if you're free. Okay, so my name's Gill Lowe. I'm a haematology consultant in the West Midlands. My area of interest is in blood clotting and bleeding disorders. So I spend a lot of my time at work looking after people who have problems with heavy bleeding on anticoagulation. And I'm here today because I'm interested in the study that's coming out and because I've done previous similar sessions with Thrombosis UK. I'm just going to ask Professor Hunt to introduce herself next, please.
Hi, Beverley Hunt. I'm a thrombosis doctor working in London, and I too see lots of women who have had blood clots, and particularly in pregnancy, which is another issue actually. So thank you very much, Gill.
Excellent. And Dr. Nicholson.
So hi, yes, I'm Pip Nicholson. I'm again another haematologist, but I'm also in the West Midlands, and I sort of have a dual role, seeing patients with bleeding and clotting problems, as well as some other blood problems. But I also have my foot in the University of Birmingham, where I do research, and I'm one of the people leading on this the design of the trial that Gill was talking about earlier on, trying to help people and finding new treatments for them who are in that situation of have bleeding whilst on blood thinning medications.
Thank you. Okay, so please do put your questions in through the chat facility. I will look at them and I will then pose them to the panel and we can have a discussion. Just while we're waiting for some questions to come in, I'm going to start asking Beverley and Pip some questions about this area in general. So we know that for women who need anticoagulation, heavy periods are a really big problem, and we perhaps don't talk about it enough. So people find out about it when they start the medication and then it happens to them. So Beverley, if I can ask you first about what you think our approach should be to a woman who is having periods and needs to go on anticoagulation. What advice should we give to her at the outset about what to expect and what to do if she's worried that her periods become heavier on that treatment?
So this is a very important area, and we all know it's been neglected in the past. So it's great to have this meeting today. For me, if I have a woman who's having periods and they need an anticoagulant, I will talk through with them the different anticoagulants, because we now know that some of the anticoagulants really are not good for women who have regular periods. And so I would always be discussing in particular certain types of the direct oral anticoagulants, the new anticoagulants that are tablets that we don't need to monitor. And I would tend to use a couple of ones, dabigatran and apixaban, and discuss with the women how they feel. They're both licensed for use to use in someone who's got a clot, and then I would ask the woman to monitor her periods after she'd started anticoagulation, and we'd have a chat after she'd had one or two periods to see whether she had problems with heavy periods. So at this stage, I don't give women anything to reduce their bleeding up front. I actually find that it's very variable. Some women start an anticoagulant and you think, oh, they're going to have problems, and they don't. And then somebody else who you think might not have a problem has very heavy periods. So we have to individualize how we manage these women. Can I hand over to Pip?
Yeah, that's great. Thank you.
Yeah, so I'm with Beverley on this, in that if I am the person who's recommending that patients have blood thinners, then I will do my utmost to counsel people in advance of what to expect, and that includes, if they are women who are having periods, to say those periods may get worse and be aware of it, and if it does, call us and give them those phone numbers to call. But what I actually find the most common situation I'm in is that because blood clots are unfortunately such a common thing to happen, that access for patients to see a blood specialist at the point of having their clot in the first place is not there. And in the majority of patients, they're seeing more generalist doctors who are doing they're practicing safely by giving blood thinners, but they perhaps aren't as pernickety about all the counselling that's done. And then I find I'm picking up the pieces later on, seeing these people who've been on blood thinners for some time who haven't been told that this was a risk. That's the more common situation I find myself in.
Yes, I think that's right. I mean, I think by the time people get to us as haematologists with an interest in this area, hopefully they're then close to, having a discussion about how the problem can be addressed. But I definitely also hear that getting a route back into services can be very difficult. And what we would expect is that anybody on anticoagulation should have contact details for a relevant anticoagulant clinic who could be their first port of call, and they would then be able to route that query appropriately. But we appreciate it isn't always that straightforward in practice sometimes. We have got a couple of questions coming through, which is great. So I'm going to start looking at them. Just for everyone's information, we won't give sort of personal advice about your own care. So I will slightly rephrase the questions you're bringing in to make them more of a general principle, but hopefully we will capture the things that you're highlighting. So the first question says, heavy bleeding started after a few years of anticoagulation and then became a big problem when hitting perimenopause, along with very low iron levels. Taking iron supplementation and pain medication on the days of my period, and the painkillers can give side effects. So which painkiller would you recommend? So I think if we break that down, so iron supplementation we know is a big problem as well, because iron deficiency because of heavy periods or other blood loss does make people feel unwell and fatigued. So that is a basic thing that we can do, is look at people's iron levels and see if we need to give support with them. In terms of painkillers for periods, that is a good question. And traditionally, I think lots of people on anticoagulation had been told to not have certain painkillers, which are anti-inflammatory painkillers. So examples for periods for that would be ibuprofen, diclofenac, or there's a medication called mefenamic acid, works in a similar way. My own practice is I am happy for people to have them for short courses if they need them, if they're helping their symptoms, rather than having a sort of blanket approach to saying you must never take them, because it's more about finding what's the right thing for you, accepting that some of these medications do very slightly contribute to the bleeding risk, but actually thinking, well, if they're managing the pain better, that may make the situation overall improved, and we can think about other ways of controlling the bleeding. Beverley, what do you think about that?
If someone's having a lot of pain, I refer to gynecology, because
Yeah,
it's beyond my area of expertise. But if they were still having heavy periods and having iron deficiency, which suggests they're bleeding a lot, and they are bleeding at a greater rate than the amount of iron they're taking in their diet, then we would offer them, initially, I would use tranexamic acid. And these are tablets that we'd give you 3 times a day, and they tend to make the blood more clotty, and the period is slightly, yes, and more easy to manage. So that would be my first port of call. What about you? What about Pip?
So yes, I agree with you that if someone's in significant pain, then perhaps it's slightly beyond my area of expertise to be managing that where simple things aren't working, and I would sort of enroll a gynecologist to help. But I guess my approach to this would be there are two main aspects. There's one which is okay, painkillers to reduce the pain that's there, but actually if you think, well, what's the cause of that pain? If it is related to ovulation, then actually other medications to try and suppress that ovulation. There are hormonal methods may be something that's necessary, but I think it's slightly beyond my experience and my expertise to be starting those things off, but I would be counselling women, people I see about that, and sort of suggesting that actually GPs are very experienced in that, and they're often a good first port of call for those hormonal treatments to try and suppress ovulation and in so doing help pain.
Yeah, so I think the principles that we're hearing here are about thinking of a cause for the pain and close liaison with gynecologists, which we've already touched on a few times now, haven't we? And I know that I spend a lot of time liaising with our gynecology team locally, some of whom have a lot of expertise in looking after women who are on anticoagulation or who have other bleeding disorders. I can see there's another comment that's come back about procedures being too risky when on lifelong blood thinners. So I think that relates to whether you may need a procedure for problems with periods otherwise. Again, my approach to that would be we would try and support any procedures that are needed wherever possible in somebody on anticoagulation, and there is usually a way of managing that, so we can provide plans for how to manage anticoagulation around these procedures. Very occasionally we may say, please defer the procedure if you can, for example, if somebody's just had a very recent thrombosis. But actually, my perspective as a haematologist is that other specialists are often more concerned about this than we are about a controlled stop to anticoagulation to enable you to have a procedure that may help you. So I think if people are sort of talking to you about procedures and saying we can't do them because of the anticoagulation, what I would suggest with that is that you ask them to contact your haematologist and your anticoagulation clinic to discuss that, because it is important that that option is still considered. Okay. So let me go to the next question. Apologies, I'm just scrolling a bit because the order is changing as more questions come in, which is a good thing. So if I'm hesitating, that's why. Okay, so the next question is about somebody who's had new blood clots on both the direct oral anticoagulants and warfarin. And so this person's saying that they're on warfarin with a higher therapeutic range because it's been increased because of the breakthrough events, and that the advice has been that there isn't another anticoagulant option. And the question is, what other options are there to control bleeding and periods in that situation in somebody who's on warfarin with a higher INR target? So Pip, I'll ask you about that issue first, then go to Beverley afterwards, if that's okay.
So I guess in this situation, I'd always be wanting to know what's been tried already to help reduce bleeding. And there's a controversy that I think exists, though whether it deserves to exist, I don't know, is that this medication that Beverley's mentioned already called tranexamic acid, there is some anxiety amongst doctors in general about giving that medication in people who have had a clot. There are many studies actually that show no increased risk of clotting, but yet the fear seems to still remain. And so that means that that medication is not used when actually it's a very simple thing that may control things effectively. So that would often be my first port of call, would be to explore whether someone has tried tranexamic acid. If they have, and it's not helping, that's when the next step I would say is going to methods of hormonal control to try and either make the periods happening at a predictable time. So that's a hormonal method of control that then you're taking tablets for a certain number of period, a certain length of time, and then stopping them and allowing that bleed to happen and sort of mimicking that natural bleeding, or whether something needs to be in place to actually stop or significantly reduce the bleeding. So those would be hormonal tablets, but also there can be hormonal injections or implants, or indeed the Mirena, sorry, not Mirena, the progesterone secreting coil. And those I find, whilst I'm not prescribing them, and I'm often asking patients to liaise with their GPs about that in the first instance, I do actually find they are quite successful in the main. I don't know if Beverley has any additional thoughts in those, or if there's any escalation that she would do in addition to those things.
Well, when I started in my career, and I'm a lot older than you two, lots and lots of women were having hysterectomies for heavy bleeding, and we just don't do so many anymore because of the progesterone secreting coil. It's also known as the Mirena coil. I shouldn't really use its normal name, but I am. And it has revolutionized how we manage women with heavy bleeding. So locally here, if you don't have fibroids, there's nothing abnormal in your uterus, we will probably recommend a Mirena coil initially if there's no response to tranexamic acid. And if the woman is going to be on anticoagulation for years and she's 30, you need a long-term solution, and something like the progesterone secreting coil really is the answer. And as Pip mentioned, there are other ways of managing the hormones too, but we almost always go for that coil. Thanks.
Yeah, I agree with that. So I think the ultimate thing is making sure you see a gynecologist with experience in this area who can then liaise with a hematologist. And in my experience, the progesterone releasing coil, some people are told it's not appropriate for them, and people may say it's not appropriate because you've not had children or things like that, but that actually isn't the case. It still can be used for management of periods on anticoagulation. Outside of the more traditional scenarios in which women would have had coils historically. So it is worth specifically asking. I completely appreciate that not everybody wants to have that. And again, my experience is that it does often take a little bit of discussion about why we're recommending it and what the advantages are. And sometimes people are, again, understandably a little bit reticent when it's first discussed. So I usually send out some generic information about it and let people have a look at that after they've had an appointment and have a think, and then we follow up after that. But we know that that is probably the thing that gives the best overall control. So that's definitely the way that I would approach this as well. I think it is difficult if you're limited in terms of not being able to change your anticoagulant because of the degree of thromboses that you've had before. So it is focusing on the gynae side of things in that situation. Okay, I want to make sure we get through everything, so I'm going to move on. We're getting lots of different things come through, which I think is reflective of the nature of problems that people have. That's exactly why we want to run this session. So the next one deals with a slightly different area. So this is somebody who's had a recent saddle pulmonary embolism and had their contraceptive implant removed because they were advised to do that, and now is on apixaban and is waiting for the first period on apixaban. So the questions as well are, could the periods be heavier because the implant's been removed, and could they be heavier because of being on apixaban? So I can start answering that. So yes, there is a risk of them being heavier because of being on apixaban. As we said at the beginning, it doesn't happen to everyone, and out of the medications we have available, we probably see a bit less heavy bleeding with apixaban than with some of the other anticoagulant drugs, but there is a possibility, and it's important that you're aware of that and that you monitor that when you do get your period. In terms of, can removal of the implant make your periods heavier? I'm not a gynecologist, so I need to caveat that, although I've done a lot of discussion with gynecologists over the years. So if you had your implant for contraception, most of those implants are progesterone based, and they do sometimes change your periods. So my non-expert opinion on that is, yes, the removal of the implant may have an impact on your periods temporarily whilst things reset. But I think the question here is more more about contraception for people who are on anticoagulation. And this is something where there's often a lot of confusion, I think, in terms of what is safe contraception that people can have. So Beverley, I'm going to ask you to talk about this first, if that's okay, and then we can have a discussion about that, about what advice you give about what contraception can be used.
So I should say at the moment, the national guidance for what contraception is safe in different situations and people have clots is being changed. I'm part of the group and I think we're nearly there. And I think that we recognize that with some hormonal treatment, the papers might say there's a teeny weeny increased risk of having a blood clot. But overall, the sensible approach would be to give a woman who needs contraception the progesterone only pill and the progesterone implant, because what are we talking about if we don't do that? We're talking about a woman getting pregnant, and the risks of clots in pregnancy are very high. So I think we're changing the guidance a bit to say, yes, we should be using these things in women who've had clots, especially if they're on anticoagulants. And there is a big move now when someone comes with a blood clot and maybe they've been on the pill, that you don't stop the pill. It may have been a risk factor. It may have been one of the things that tipped that person's blood over to making clots. But once you've got someone on anticoagulation, it's a counterbalance. And we don't really want them to get pregnant. That would make life a real mess. So internationally, I think that that's where we're going. So I think we have to feel a bit more reassured that most of the contraception that doesn't have estrogen in it is pretty safe. I can see Gill shaking her head, nodding with me.
Yeah. And I think, again, you know, it's understandable that if you see, for example, a GP, they will be cautious, which is the right thing for them to. They don't want to do anything that's going to harm you. Most regions have a service where GPs can contact haematologists for advice, even if somebody's not coming to clinic. So we have a service called Advice and Guidance, which Pip and I participate in, and we get lots of queries along these lines there. So again, the important thing is asking, because I agree with what Beverley said. What we don't want is somebody not having access to contraception they actually could have safely, and then getting pregnant having not wanted to become pregnant, because actually the blood clot risk in pregnancy then is even higher than it is considering some of these other medications. It's a slightly different scenario if you want to have a pregnancy when you're on anticoagulation. That's probably outside the scope of today's discussion, but that's certainly something we could look at with Thrombosis UK at a different time. There's so many aspects to women's health with thrombosis and anticoagulation. We did a recent session with some gynecologists that was focused more on care of the menopause and fertility, but there are lots of different facets to this. Okay, I'm going to move on to the next question. So this one is somebody who already had heavy periods prior to having thrombosis, and was anemic at the time that they were diagnosed with their saddle pulmonary embolism. And this person said, I'm lucky to have a haematologist who is pushing gynecology. Not lucky, that's just what you should be getting. But yes, I appreciate it's fortunate that you've got people who are giving you the care that you deserve. And they've said that they saw the gynecologist, were discovered to have polyps, and are waiting for an operation to have them removed. So that goes back to the point that we said earlier about you should have procedures that are needed to help with management of your periods, because it may actually help in the long run and mean that we can give you your anticoagulation more safely. And this person's commented, my periods are horrific since going on anticoagulants, slightly better on apixaban compared to warfarin, but the first few days the pain is very difficult and the bleeding is extreme to the level that I can't leave the house. And I think that raises another important point about the impact all of these things have on quality of life. So when we do studies in these areas, as doctors, we're often quite focused on the volume of blood you lose in a period or your hemoglobin. Actually, the quality of life that you're referring to is probably the most important thing. You know, what we want is to be giving you treatment that means you can live a normal or as normal as possible a life. So I think, unfortunately, that story of the impact on your personal and day-to-day life is something we hear frequently. But it's good that you have an option in terms of having the procedure to try to at least start helping with this. Okay, let me scroll. There's lots of other comments, which is great. So there's a question about what are the title of the articles about tranexamic acid not increasing clotting risk. Beverley, I'll let you comment.
Okay.
Yeah.
So if you look at all the trials where tranexamic acid has been used short term, doesn't increase the risk of having blood clots. And so we use it to reduce bleeding in trauma patients. We use it in postpartum hemorrhage. We just have a couple of shots of tranexamic acid and it actually reduces death due to bleeding. We've done huge trials to show that. And if you go to hospital now and you have a big operation, the government ask that you should have tranexamic acid over the period of the operation to reduce your bleeding. So it is much more widely used, though not everyone sort of seems to have taken it up. The only little if about tranexamic acid in using it in periods is that the Danes have looked at the use of tranexamic acid in women having periods. And we don't really know why they were having tranexamic acid and whether they'd had clots before. But so it's a big study that they said, oh, all these women are taking tranexamic acid. And then they looked to see if any of them had had clots. And there was an increased instance of clots in those taking tranexamic acid. But we don't know whether they were taking tranexamic acid because they were on anticoagulation because they had a clot before and then they stopped taking the anticoagulant. So it's a little bit, and it's very soft data. It's only a slightly increased risk. So the National Institute of Health Research in the UK have said this is a research question we need to answer. So we are hoping to design a study that PIP will lead on where we can look at that very question and see whether tranexamic acid actually does slightly increase your risk of having a blood clot. So very long answer for a very short question. I'm sorry, but that's how it is.
Though I think the question was asking the names of the studies, and if someone is that interested, I guess they were the studies you're referring to are CRASH 2 and the woman study, and POISE 3 was the surgical one, wasn't it? So I think those are the ones that you should look at.
There's 180 randomized controlled trials of TXA and surgery. We definitely know it works.
Absolutely. And I think, you know, the reality of medicine is that we are sometimes making balance of risk decisions for things where we don't, you know, absolutely have evidence that one thing is the right thing or not to do. And that's why this question's arisen, that now, you know, there's the call for a research study to answer. Some other sort of points really that are being made, which I think are worth reiterating. So one about the number of specialists that people on anticoagulation end up needing to see, and coordination of care. And I definitely hear that a lot. And I view my role for my patients often as helping them to coordinate that, because sometimes it's easier for me to contact another specialist than it is for them or somebody else who doesn't look after as many people on anticoagulation. But the point that really having involvement from that number of specialists can be mentally draining. And I definitely see that, you know, it's a very difficult system to navigate sometimes. And I think there's more of a trend nowadays to, you know, involve individuals in their care, which is an excellent thing. But I definitely see sometimes that people then feel that they're trying to coordinate between their different specialists, which can be very, very difficult. So that is a, you know, a well taken point and something that's very important. And then another point about if a coil is considered or needed, as we discussed before, who should put it in? So the question is about, can anybody do it, or does it need to be done by someone with expertise? I think this varies a little bit region to region. So purely for ease, I do often refer these patients to my gynecologist colleague. Obviously, that's not always that easy for individuals because they need to come into the middle of Birmingham for an appointment, but it does often happen quicker that way. If a GP contacted me and asked if they could do it, I wouldn't have any objection to that being done with a discussion beforehand. But my experience is that people often do struggle to get it done outside of a hospital environment. I don't know what your experience is, Beverley, on that side of things about getting the coils put in if they are needed.
Well, our local GP practice have very good coil service. I think it varies from area to area. So I can't speak for the country, I'm afraid.
Okay, so I think, but that's an important point to highlight, because even between us, we have slightly differing experiences. But I think what I would say in answer to that question is there's no reason it can't be done in a GP surgery. Absolutely not. It just needs a discussion about how it's managed. It's a very low risk procedure. You know, the bleeding from the procedure itself is minimal. So it sounds like the person asking the question's got a good GP, because you're saying that your GP said they would do it. So that's absolutely fine. As long as they know you're on anticoagulation, there isn't a reason it has to be done. It's sometimes just done that way because of the working relationships already being set up and it being a bit easier for another doctor to access a service in a hospital. And then another comment about gynecology wait times. Yeah, I mean, we certainly aren't immune to this in Birmingham, and I suspect it's similar elsewhere. The waiting times are a massive problem. Even to see a haematologist, and I saw further up the chat somebody had made a comment about the time it took them to see a haematologist after their DVT or PE was diagnosed, and I think that is difficult because that first appointment, hopefully for a lot of people, answers a lot of the questions that you've been living with since your diagnosis. So we certainly are aware of that being a problem. I think we all try our best, if we know there's a new patient, to see them as promptly as we can. And we have excellent anticoagulant specialist nurses who will do the first discussion before you see a consultant. But unfortunately, I think with the current, restraints on the NHS, that is a problem that we have that we can't immediately solve. I don't know, Pip or Beverley, if you've got any comments on the wait.
Yes, I mean, we run our DVT and PE service, so all the patients see us consultant haematologists at 6 weeks, and we're lucky to be able to do that. But Thrombosis UK is very aware, huge variability in the number of haematologists who've got an interest in blood clots across the country, and there are areas of Yorkshire where there isn't one. I know because people come from Yorkshire to my clinic in London because there isn't anybody there. So I know about that. And the other thing is that the government recognise there are major issues with gynecological service. And there's been a recent report, and they're trying to establish more services. And then locally here, our gynecologists are trying to move out to the community and run clinics in GP practices or healthcare centres. And I think that's probably where we are going. Certainly the recent NHS report on the next 10 years says we need to move all the outpatients to community. But whether that means they're more accessible and that because there are more gynecologists, I'm not sure.
And I think in terms of sort of inequity in access to care, I know that the Thrombosis UK team do sometimes put individuals in contact with doctors who have an interest, as you said, Beverley, about people coming to see you. So I think if you feel that you're in an area where you're struggling to get that support, it's certainly worth asking Thrombosis UK if there's any support that they can give you with accessing people with expertise, or indeed in knowing who you might go to within your own area, because it may be that they're aware from other people who've sought support for them about which services they've accessed. So we're aware that you can feel very alone as an individual going through this, but there is support there where you can certainly ask the question. Okay, I think we've got to the end. We've covered all manner of issues there, haven't we? But it's actually been good to see the questions that come through, because I think they've highlighted the things that people see. So we've been going for about 35 minutes now. I'll talk for a little bit longer. If you've got any last questions, put them in now. But if not, we'll wind down and stop soon with a view to having the follow-up session, which is more specifically about the study that we're thinking about next week. We're very, very grateful to everyone for coming. I hope it has been helpful. I can see some of you have put comments to say thank you for the responses. So I'm pleased that some of the discussion's been useful. I know that Thrombosis UK will carry on having sessions like this, and the previous gynecology session is available, I understand, on catch up. So it's worth having a look for that as well, and letting the Thrombosis UK team know if there are specific issues that you'd like addressed in future sessions. Okay, I don't think any more questions have come through. I'm going to ask Pip and Beverley for any closing comments, and then I will finish. So Pip first, is there anything you'd like to comment from our discussion, or any final words you'd like to say?
I mean, I think so. The questions, when I'm reading through them and just seeing something that may be wondering, have we answered it as definitively as we can? There are two things. One is about the use of contraception in people on anticoagulation. I can see there's comments here saying I've seen someone because of my brain clot in particular, I can't have any form of estrogen or progesterone. And what's difficult to comment on without knowing the specifics of the case is who's given that advice. Because I would view that it's a course that people who are aware to some extent of the literature and know that estrogen contraceptive pills have an association with clots, then want to be safe and expand that beyond the actual evidence base. And I think those blanket statements of no contraception is safe are simply just not reflective of the evidence. Beverley said that the risk is I think I would say the risk of progesterone containing contraception on clots is almost non-existent.
Tiddly widdly. Yes.
Tiddly widdly, there we go. I don't know if I need to use those terms.
It's a proper scientific term.
It is. And the risk of estrogen containing contraceptives is really only confined to the pill and not to implants and not to transdermal patches. And that's only in people who are not taking blood thinners. And so if you're on blood thinners, all of these things are actually okay. And we should be focusing far more on people's quality of life and what the bleeding's doing to them, rather than the piddly widdly risk of increased thrombosis. That's my closing.
Also, only the estrogen containing pill, the mini pill, the progesterone only is acceptable, and we would usually say something along those lines. We also get similar queries about HRT for people at a different stage of life, about what forms of HRT you can have with anticoagulation. But I think the general principle here is to make sure the question has been asked to someone with thrombosis expertise, so that there isn't over caution that's then limiting the options that you've got. Okay, Beverley, any final words?
Yeah, the last one is the level of knowledge is variable. Yeah. Doctors just can't keep up with everything. Everything's moving far too fast. And so that's really why, if you're really stuck, you need to see a hematologist with thrombosis expertise, but there aren't many of us. And then the big one for me, as I got phoned so many times or emails about, can I give HRT to someone who's had a clot? And the answer is you can use as much transdermal, the patches, the spray-ons as you like. They have no risk at all. It's the tablets. So because some women on this call will be coming up to the menopause, and you need to go for transdermal HRT, no increased risk of clotting. Thank you.
Absolutely, yeah. And actually, over the last couple of years, I've started making that comment about HRT when I see someone, who's much younger, because I know that question will come up. So I tend to put in my letter in the future, transdermal HRT is acceptable, but, oral should be avoided. So at least that's on somebody's record, because obviously this becomes a point of concern, as time goes on. So I think being clear about it from the outset really helps. And I can see lots of people are commenting now to say they're pleased to hear the things that we're saying now, which is good. Okay, that's great. We will conclude there for today. I feel like we could go on all day. We're very, very grateful for your insight and time, and we hope to see some of you again for the session next week. I think Joe from Thrombosis UK has put a comment in to say that you'll get a follow-up email about that session, so please do join that if you can. Somebody's just said, Beverley, they're going to take a recording of what you've just said to every medical appointment. You're better to do it with Beverley than me, because my accent might cause a problem if you did it.
No.
I'm just joking. Anyway, yeah. So we hope it's been helpful. We'll conclude there. Have a good day, everyone. Thank you very much. Bye.
Thank you for your time.
Thank you.